So today learn about wound management part 2, that is on cancer wound. So I have a small request. Please switch on your video. So I'd like to see you all. Good afternoon. Okay. So let's start our class. Last week we have learned about pressure sore management. What is pressure sore? What are the stages of pressure ulcer? So how will we manage and how will we assess those things we have learned. So today I would like to do the recap on the last class and then move on to the today's session. So I'd like to share a patient story with you all. Then you can read it, one of you can read it out and then we can discuss. Okay. So this is the case scenario. Anyone please read it out? Anybody?
Case scenario.
Ah.
M, 60 years, is a bedridden patient following fall from a height 3 months ago. He has lost sensation and motor power below umbilicus and is having incontinence. He is unmarried and lives with his older sister. Both of them do not have a fixed income. You are the nurse on home visit and find that Mr. M is having the 3 ulcers, one on sacral area exposing the muscles and other 2 on each heel with loss of skin. What are the stages of the ulcer mentioned? Mention 3 risk factors and 3 preventive strategies in the care of the ulcer in this patient. How will you manage this patient?
Okay, thank you, Shiny, for read out the patient story. Uh, we can discuss. So, what are the stages of ulcers mentioned here? If you have seen this type of patient, so you have to be documented properly, right? So what the first pressure sore is on sacrum. So that is exposing the muscles. So what is the stage? Please unmute yourself and talk. We all nurses. Anybody? So Praise is at third stage.
Yes, ma'am. Good afternoon. It is third stage
Okay.
ulcer.
Okay. Kanchan said third stage. Okay. Others, please respond. Anybody? Grade 3, grade 3. Okay.
Grade 3, ma'am.
Okay. What is the other one? Two pressure ulcer on heel with loss of skin. What is stage? What is the stage?
On the heel, it is first stage bed sore ulcer.
Okay.
Peeling of the skin is there. No, it is first stage.
Okay. Anybody? Others, please respond. Simon said the grade 2. Okay. So the answer is the first. Okay. Sorry, ma'am. It's second stage. Okay. Kanchan corrected. It is not a first stage. It is the second stage. Ulcer on heel. Okay. So thank you for your contributions. But the first pressure sore on sacral area that is exposing the muscles, it's fourth stage. Okay, so the first stage is non-blanchable erythema, that is only redness. If you apply pressure on that, if there is a red color there, if you apply pressure on your finger pressure on that area, that redness remains there. That is non-blanchable erythema. Okay, that is first stage. If there is any peeling happen, if there is any blister formation or peeling there, loss of skin there, if the dermis layer will damage, maybe loss of skin there, that we called a second stage. Okay, so that time there's a partial thickness will be there. The third stage is full thickness, but the subcutaneous layers will be affecting, not exposing the muscle, bone and tendon. So that is third stage. The fourth stage is muscle, bone, tendon will be affecting. The fifth one is unstageable. If there is a black necrotic tissue on the top of the skin, we can't assess the stage. That is why we call it as unstageable wound. Once we remove the top of the black necrotic tissue from the unstageable wound, then only we can able to find out the stage. Okay, so the first the sacral area pressure ulcer is stage 4, and the other on each heel with loss of skin, that is stage 2. Okay, so the next question is mention 3 risk factors and 3 preventive strategies in this care, the care of the ulcers in these patients. So what are the 3 risk factors? You can from this patient story, just tell me what are the risk factors of these patients can develop pressure ulcer. Okay, bedridden, maybe because of bed, he is a bedridden patient. Immobility can cause pressure ulcer. Okay, immobility is one of the risk factor. Okay, N. Other points. Incontinence of urine. Anupama said incontinence of urine. Very good. Okay. So moisture is another cause of pressure ulcers. Here this patient is having incontinence of urine. So that may be the another risk factor of presenting developing pressure ulcer. Okay. So again, malnutrition, poor nutrition, very good. Again, this patient is having loss of income also. Maybe the patient is not getting adequate nutritional support. Maybe because of that also, the patients can develop pressure ulcer. So these patients maybe one is immobility, and the another thing is incontinence of urine and malnutrition. So these are the possible that risk factors for this patient. Okay, and also friction, shear, these all things will be there because this is a bed-bound patients. They need to change the bed sheets. The caregiver, sometimes the caregiver doesn't know how to change the sheets, so they used to pull the sheets under the patients. Their idea is good, but it will damage the skin. So that way, the patients can develop pressure ulcer. But in this case, one is immobility, not able to turn independently. They need help. Every 2 to 3 hours, we need to change the position. Maybe because of immobility, the patient can develop pressure ulcer, and the next thing is incontinence of urine, and the third one is malnutrition. Okay, and what are the 3 preventive strategies which you have tell these patients? You have instruct the patients. You can just, whenever you have seen these type of patients, you have to tell the just give, definitely you will give some instructions how to prevent pressure ulcers. So what are they? Any idea? Second only position change, very good. Okay, so whenever you have seen a patient in a bedbound conditions, you have to tell the that encourage the patient and caregivers about the importance of changing your position. So and the next one is back air. Whenever you have changed the position, you have to check the pressure points and you can provide a back air. So at least they can take a moisturizing agent in their hand and give a massage so that the blood circulation will increase, and that way we can able to prevent that pressure sore formation. Okay. And the next thing is about bedwetting. So this patient is having incontinence. So if possible, you can do Foley's catheterization. Otherwise, they can use if affordable patients, they can use a diaper. But this patient is not affordable. If they are not willing to put the catheter, they can use their own sheets. But the thing is, if their linen become wet, they have to remove, change it as soon as possible. So otherwise, moisture is another cause. So you can provide airbed, and whenever you provided, you can suggest airbed or waterbed to the patients. You have to tell them this is not a 100% solutions. They need to change the position. Okay. So otherwise, they might be thinking that airbed or waterbed will take care of everything. So have to tell the fact also. And you can advise to take high protein containing diets, and if they are not affordable, you can try to give food kit, or maybe try to arrange some financial support to the patient so that they can get adequate nutritional supports also. So these are the things where we can able to prevent pressure ulcer formation for this patient. Okay. So how will we manage this patient is also, you can educate the patient and empower the caregivers. Without caregiver support, we can't do anything. So we have to empower the caregivers, and we need to demonstrate the patient care, wound care, and position change, and change the sheets and all. If possible, you can demonstrate to the caregiver so that they can get good idea, and you can educate wound care also. Along with that, you can provide some food kits and maybe financial support and all. So that way we can able to manage this patient. Okay. Thank you. Thank you for your contributions. So this is our today's class, fungating wound or a cancer wound. So I'd like to ask one question about what are the difference between fungating wound and pressure ulcer. So otherwise, one important, you can just share one important major difference between pressure ulcer and fungating wound. I am waiting for your answers. So what is the major difference between pressure ulcer and cancer wound? Bad smell, necrosis, foul smell, bed sore, bad odor, okay.
Good afternoon, ma'am.
Yeah, good
Ma'am,
afternoon.
cancer wound is a part of disease.
Cancer wound is?
Cancer wound is a part of patient's diagnosis and
Okay.
disease. On other hand, fungating wound, the wound which as patient is bedridden has wound due to poor nutrition and immobility and
Okay. Thank you. Yeah. Tell me. Thank you. Any other answers? We all nurses, you might have seen different that fungating wound or cancer wound and bed sores in your career or maybe your working place. You might have seen different types of wounds and all. So I just ask you about the difference between two. Any other answers? No. Fungating wounds are like a diabetic foot. Bed sore external wound, cancer wound internal. Bed sore or over bony prominence, other wounds can occur on tumors. Very good. Some cancer wounds are hard. Thank you, Srilada, for contributing this. Okay. So one of the major difference between pressure ulcer and fungating wound is the pressure sore is preventable and curable. Most of the time the pressure sore can be curable. So if there is a fourth stage also, if the patient's health condition is okay, we can able to cure it. But fungating wound like cancer wound is not preventable and not curable. This is the major difference between pressure ulcer and fungating wound. So what is fungating wound? It is a primary or secondary malignant growth in the skin which was ulcerated and difficult to heal. So once the wounds develop, we can not heal properly. So this is the definition of fungating wound. So it refers to a malignant process involving both ulceration and proliferative growth. It looks like a nodular fungus shape. That is why we call it as a fungating wound, not because of fungus. It looks like a nodular fungus shape or a cauliflower shape. Okay, so this is what fungating ulcer. So what is the pathophysiology of fungating ulcer? So we all know the growth. Okay, there is a tendon. Usually, the develop a non-tender skin nodules in the skin. So gradually, the nodules will enlarge. So if the nodules enlarge, that leads to disruption of capillaries and lymph vessels happen. If that happen there, altered coagulation and disorganized circulation will be there. Finally, tissue hypoxia and necrosis will happen. So this is the pathophysiology of cancer wound. Okay. So how many of you heard about Marjolin's ulcer? So this is the malignancy of the skin, malignant changes of in a chronic wound. If, for example, so burn scar ulcer and pressure ulcer, chronic pressure ulcer and venous leg ulcer. Sometimes the cancer can develop from these kind of wounds. So the malignant changes come from the chronic wound, that is Marjolin's ulcers. So that pathophysiology is little bit different. So appearance of mass in the wound. So it look like a granulation tissues. Okay, not previously present. And after that, the patients, if there is a mass in the wound, the patients will complaining of sometimes when you do the dressing, that time the patients complaining of pain also. So and also some changes of character, volume, and appearance will be there. That drainage there is not previously present. The lot of exudate and that shape will be changing. That all kind of changes will be there that time. If these kind of changes there, better you can refer the patient to the oncologist and take biopsy from there, and then you can find out whether the wound has a marjolin ulcer or not. So if there is anything happens, so this is a curative possibility cancer. Better you can, if these changes there, you can you can refer the patient to the oncologist. So coming to the problems. So from the beginning itself, we learned about what is the aim of palliative care. So the main aim of palliative care is to improve the quality of life of their patient and their family. So sometimes we can't cure their the disease, but we can care as much as we can. Okay, so here also this is a non-healing ulcer. This patient needs for that aspects care. This patient need physical care, psychosocial support, social support, and spiritual support also. So we unfortunately we don't have a case presentation today. So I have a patient case scenario here. So I'll read out, and then we can discuss it. Then we can move on to the further part. So this is the case scenario. 65-year-old man diagnosed with the cancer, right buccal mucosa, see, living with his family. So he came to your OPD for cleaning and dressing. His main complaints were foul smell and exudate. So while doing the dressings, he asked, "My wound is healing well, isn't it?" The questions towards you. So you knew that fungating wound is not curable, but the patients will be asking you, "My wound is healing well, isn't it?" How will you respond to this question? So just imagine a 65-year-old man diagnosed with a severe buccal mucosa, is not able to speak fluently, but we can able to understand. Living with his family, he came to your OPD for cleaning and dressing. He is asking this question. So how will you respond? So during the communication session, we understand that don't give false hope to the patient. Here also we knew that. So this is not going to heal. The wound's size is worsening. But the patient says like, "My wound is healing well, isn't it?" How will you respond? So I would like to hear from you all. Please unmute yourself and talk. Nancy, please unmute yourself and talk. So how will you respond?
Yes, ma'am. We can tell it's healing. Do you agree? Not, but we can tell negative comments, no?
Uh, so how would you, please help Nancy. Someone please unmute yourself and talk. So there is no right or wrong answers. Please unmute yourself and talk. Saraswati.
And we can tell that the wound is still there. We'll let him know that the wound is still there, but we'll not directly answer the question by saying it's healing or not healing. We can say that the wound is still there. It might take some more time for it.
Okay, wound is visible. Okay, wound is still there. Okay, that's he knows. But his question is, my wound is healing well. But we know that the wound size is increasing and not healing well.
We can tell him that it will take some more time, because we can't tell him that it will not heal completely, and we can't tell him that it's healing because it will not heal.
Okay. So we can say like better than before. Who says just we can say better than before. Simon Peter said that we can we. Make sure patient family member is there while explaining about the wound's condition calmly so that he can take proper treatment. It will take more time to heal. Okay. So, but we know this wound is not going to be healed. Okay. It will take time. So that time the patient, the hope will be there and the patients will be expecting cure. Okay, here you don't need give no hope. So and the another thing is Liana said tell him he is doing a good job at keeping it clean depending on how it looks. He needs to know will be long journey, show process and goal too. Okay. So Esther said, yeah, there is some improvement. But we know that there is no improvement. Okay. So you have to, the thing is usually we get these kind of questions. While we doing the dressings, usually the patients might be asked like this. So that time what you can do is you can just listen. Okay, we'll see. So that's so also you have to tell. Then gradually not take it as a challenge and make them understand. You have to do one thing, listen and we'll see. So then gradually maybe after 2 or 3 weeks they will come to you and say like, okay, my wound size is worsening. So if we know this wound is not going well, healing well, not healing well, and wound size is increasing, and also if you take it as a challenge and make them understand that they might be angry and lot of problems will be there. So you have to leave the patients as there and gradually they will understand. So you at least do one thing, you can listen their problem, listen their concerns and just say like, okay, we'll see. And the next question is, why God punished me like this? After few hours, he might be asking like, why God punished me like this? So I'll come to you this question later. So this is the physical and psychological problems. So just imagine a patient, imagine that patient see a buccal mucosa and proliferative growth on his face. These are the some physical problems he might have developed. So one is pain because of proliferative growth. The direct exposure of dermis can cause patients can develop nociceptive pain. Sometimes the tumor will be compressing to the adjacent nerves and blood vessels, that time the patients will develop neuropathic pain. So, and the another thing is, we all know that the dressings are adherents to the wound. So before soaking the wound, when if we try to remove the dressings from the wound, that way the patients can develop pain. So these are the three ways the patients can develop pain. And the next thing is malodor. So lot of devitalized necrotic tissues will be presenting in this type of wounds. So that time the malodor will be coming out. And the another thing is tail exudate dressings have been placed number of days. So they might not be maybe not able to change the old dressings that maybe clearly, that maybe because of that also the patients can develop malodor and bleeding may again. So improper dressing techniques can cause bleeding, and the another thing is the tumor will be protruding the major blood vessels. That time also the patients can develop bleeding. Exudate means oozing out of pool and discharge and fluid from the wound. Maybe in this type of wound, inside the wound the blood vessels will be dilate. So that time the loss of oozing or that fluid will come out. So that is exudate. And the another thing, and also if there is an infection, so like there is a lot of necrotic tissues will be present into the wound, that time infections will be there, inflammation will be there. If there is inflammation there is a chance of fluid formation. That is that way also the fluid will come out. And itching, sometimes itching will be there, infestation with maggots, the maggot formations will be there, and communication difficulties, especially head and neck cancers. They are not able to communicate properly. So that time what you can do is, if they are able to write down their problems, you can give a sheet of paper and ask them to write down their problems, so that we can get a good idea about the patient's problems, and we can treat the patients as their problems as much. Maybe we can able to that understand clearly if they are able to write down their problems, if they are not able to communicate well. And psychological problems, also altered body image. Just imagine a huge fungating ulcer on his right buccal mucosa. So here altered body image will be there. So we all know that if we have a develop a small pimple on our face, so if we get a chance to see the mirror, so we'll go and see, okay, whether that size is increasing, decreasing. So we are that maybe anxious about the marking and all. Maybe after that, the black color spot will be there. That we will be anxious about that also. Here, just imagine a non-healing ulcer on his face. Gradually the size will be increasing. The symptoms will be increasing. Pain, like pain, malodor, bleeding, exudate, all those symptoms will be increasing. That will be affecting the patients emotionally, and sexuality will be affecting. So nobody is willing to do do this sexual intercourse, because maybe because of misconception of disease and denial also. So sometimes positive and negative denial will be there. Sometimes they know the wound size is increasing, but keep inside the mind, and then ask you like, so whether my doctor or sister, my wound size is decreasing, right? That kind of questions will be there. So you can just listen and leave the patient there. So we'll see like that. Then not take it as a challenge and make them understand, no, it is not going to heal more. So if they are now don't know the diagnosis, you can if they really want to know the prognosis of the wound, you can do it as a breaking bad news protocol, like a spikes protocol. And fear also, so they will be anxious what is going to be next, and if they are not getting well, that symptoms increase, they might be go to depression also, and shame, guilty feeling. So these are the psychological problems. And coming to the social problems, here also family isolation will be there. If one person can develop these kind of illness, the family members can choose a corner side room and keep the patient there. So that will be affecting the patients emotionally. And social isolation also, the society like neighbors, friends, relatives are not willing to see these type of patients, maybe misconception of disease, and maybe they might be afraid about to spreading of the disease. That kind of things will be there. Social stigma, fear of contagion, effects on family, and effects on sexual relationship and marital disharmony, because nobody is willing to marry this kind of family, because they might be thinking like the spreading of disease and hereditary, that kind. So these all will be affecting the patients emotionally, or maybe this is only because of me, my daughter is not getting married. So that kind of things will be affecting the patient emotionally. And come to the spiritual part, interference with religious, that might be thinking like maybe because of my sin, God punished me like this. These kind of things will be there. So coming to the assessment part, wound location. So always you have to assess the wound location. Is it mobility impaired, or easily we can able to cover the wound with public view. So this is very very important. I have a patient. When he came to the OP, that he brought a big towel with him. So I was asking him, why you are brought this kind of long towel with you always, all the time. So after then he told me, so this is very so this is the very this is one of the essential things for me nowadays. I asked, why you're saying like that? Then he told me, so after your dressings I'll tell you the truth. Then okay, so I did her his dressings. So now after that he took his towel and that cover his face. So he was having a buccal mucosa wound, that after dressings he has covered the whole that part. So then I asked him, why you are covering this covering like this. Then he said like, okay, if I am not covering this properly, nobody is willing to sit near to me, and when I go out of this hospital, everybody is that look at my face and ask me what happened, like that kind of things, that kind of questions will be there. So I have faced lot of questions. So if it is covered properly, please cover it properly, so that I can able to cover it properly, and so I am comfortable to travel anywhere. So that kind of things will be there. So if possible, you can cover the wound properly from the public view. And wound appearance also is very important, surrounding skin potential for complications. So this is very very important, because head and neck cancers, so they might have developed profuse bleeding. Maybe the tumor will be compressing the blood vessels and develop profuse bleeding. If it is happened in their home, so the caregiver should know how to that manage that situation. So that is very important. If there is a head and neck cancer patients there, so you have to prepare the patient family for that. Coming to the management part, so try to relieve their symptoms. Palliation of symptoms is as much as possible, you can try to solve their problems. If they have pain there, you can try to reduce their pain. If they have odor there, infection there, you can try to reduce their odor and infection. managing exudate, minimizing bleeding. So if you reduce their symptoms, definitely we can able to improve the quality of life of the patient. And you can provide holistic care. Holistic care is total care. Physical, emotional, social, and spiritual care is needed for this patient, and empower the patients and family in wound care. This is very, very important. So whenever the patients come to you for dressings, you have to empower the patient caregivers also. And when we do the assessment, so if possible you can do the individual assessment, because in front of the caregivers they won't tell the truth, because if they are doing alone the dressings, they will be telling that the caregivers will be doing my dressings and all. So that kind of things will be there. If possible you can do the individual assessment, then you can able to understand the real situation. So, and criteria for dressing is our aim is to improve the quality of life of the patient through good symptom control and empathetic care. So, always you have to think if our friend or if our relatives are there, you can put yourself into their shoes. So, you can always think like that. This patient needs an empathetic care, and if possible, you can do a thorough bath before dressings, because that this kind of wounds are fragile, and a lot of necrotic tissues will be presenting on the wound. So if they are able to do a thorough bath, so all necrotic tissues will fall off. So without touching your artery fossa, that most of the necrotic tissues will fall off. So better you can tell the patient to take good bath. And after that also you have to, before doing the dressings, you have to ask the patients about the pain. Okay, so make sure the patient is having no pain. Okay, if they have pain, you have to give some analgesics and make the patient comfortable or pain free, and then you can do the dressings. Use normal saline for cleaning the wound. Select dressings depends upon the size of the wound and exudate the maybe quantity of exudate, maybe severe exudate there, you can change maybe every 2 to 3 hourly or 4 hourly change, dressing change will be needed. So coming to the pain management, if they have pain, so I was talking about two different types of pain, nociceptive pain and neuropathic pain. You might have that maybe learned in the pain session two different types of pain. Nociceptive pain and neuropathic pain will be there. If there is a neuropathic pain there, your systemic analgesics may not help. So that time you have to give some local anesthetic agents. Okay, if there's deep pain like aching, stabbing, continuous, that kind of pains there, your systemic analgesics will be help, because for example, if they have taken 10 milligram morphine for their pain, so that if the patient is having a deep pain in the wound, so that narcotic opioid will help that patient, because that time if they have pain, that time you can give a breakthrough dose, extra dose that time, and then after 45 minutes the patients will get adequate pain relief. But if the patient is having neuropathic pain, your that adjacent the systemic analgesics like morphine, sometimes most of the time it may not work well. So that time you can apply local anesthetic agent like sensorcaine or silocaine. Okay, so you can take 1 ml and add another 2 ml of normal saline, and depends upon the size of the wound you can take and diluted this local anesthetic agent, so that you can pour the wound, and after 2 to 10 minutes the patients will get an anesthetic effect to the wound. That time you can do the dressings. Coming to the malodor management, so here there are a lot of necrotic tissues will be there. That time the patients will develop malodor because of that anaerobic bacterial infection. So the one of the drug of choice of anaerobic bacteria controlling anaerobic bacterial infection is metronidazole. Okay, so you can take a metronidazole and crush it, make it a powdered form and apply on the wound. And the another thing is you can use injection metronidazole also. So because there are a lot of pocket formation inside the wound, so your that powdered form metronidazole is not going to inside the wound because so there are a lot of pocket formation. No, so if you are using metronidazole injection, they go inside the that all fistulas and all that pockets that even the small areas, and then that way we can able to prevent control infections. And also you can do you can give antibiotics also, but it may not help well, but you can try one course of antibiotics. Frequency of dressing change depends upon the that exudates. And also that stale exudate dressings, the also if they the place have been placed in number of days can cause malodor, so that they have to change it maybe at least twice. If it is there is no the lot of exudate there, they can change every 4 hourly or 6 hourly. No, here also no hydrogen peroxide and betadine. This is the both are that hypochlorite solutions. This will be irritating the wound, and it may not help to the wound. So because this is not going to heal. Day by day the size will be increasing. So no need to apply hydrogen peroxide and betadine for this wound. Coming to the bleeding management, always try to prevent, because improper dressing techniques can cause bleeding, because dressings are adherents to the wound. Without soaking the dressings, if you try to remove it from the wound, so might be develop bleeding. So try to soak the wound well and remove the old dressings. That way we can able to prevent bleeding. If there is a bleeding there, apply local pressure. We all know that how to do it. You can apply local pressure on that area. So if it is not that control, you can apply sucralfate powder as the same medicines as which we have used for peptic ulcer treatment. The same sucralfate powder as another action also. You can crush it and make it a powder form and apply on the bleeding part. And tranexamic acid also you can apply. And then if the bleeding is not controlled, then you can move on to the systemic ethamsalate and palliative radiotherapy also. Then if they are doing the palliative radiotherapy, that will help to strengthen the size of the tumor. So if the size is strengthened, the size is reduced, that there is a chance of we can able to prevent. There is no chance to profuse bleeding, so we can able to prevent profuse bleeding for some time. And you can tell the caregivers about the management. They always use dark color clothing. So if it is happen in their house, if there is a profuse bleeding happen there, they can use dark color cloth for wiping out of the blood, because that way we can able to prevent the anxiety and panic. So they will be panic, because if they are wiping the blood with that white color cloth, the patients will be panic, and the other relatives also become panic. So that way, if they are using dark color cloth, so that way we can able to prevent. So nobody seen that red color. So that way we can able to prevent anxiety. So role of cancer therapy is radiotherapy, cytotoxic chemotherapy, hormone therapy, and surgery. Surgery is debulking surgery. If the patient's health condition is okay, you can think about that also. And radiation, cytotoxic chemotherapy, and hormone therapy, these all things will help to reduce the size of the tumor. So reduce the size of they will help to strengthen the size of the tumor. So if that way we can able to prevent bleeding. So coming to the maggots part, So I would like to hear from you. How does maggots come? How does maggots come?
Ma'am, we can use terpene oil to remove the maggots.
Okay, so that is the management of maggots. So my question is, how does maggots come? Sumit said due to flies. Any other answers? Due to pus. Then
Maggots come because, ma'am, dressing was not properly done with sterile technique.
okay. So unsterile techniques can cause maggots. Kajan said due to not proper care of patient's own, failure to do dressings. Okay, direct contact with any insects. Okay, thank you. The maggots, sir, come from flies, so house flies. So this is very, very important. The patient don't, the patients don't know the how to maggots come. The patient doesn't know how to maggots come. So you have to tell the patient about how does maggots come. It come from flies. They need to cover the wound all the times. So otherwise what happened is if the house flies, usually the house flies are attracted with the infected wounds. If there is an infected wounds there, the house flies are attracted. So when they touch the wounds, they may lay eggs. So after 6 to 8, 12 hours, they come out with maggots. Okay, so this is very, very important. You have, whenever you have seen that wound patients, while you doing the wound dressings, you have to tell the patient and the caregivers about the importance of covering the wound. So otherwise, maggots will be developed. So that you have to tell the cause also. How does maggots develop? That it can develop from the house place. That message also you have to convey. So if there is a maggots there, you have to remove it because physical removal is the only way to remove the maggots from the wound. So if they are able to that cover that area, that bed with the mosquito net, that will be good. So otherwise they have to cover the wound properly. And so you can how you can remove the maggots is once the patients has developed maggots, you can apply turpentine. So not directly pour to the wound, you can soak the turpentine with the gauze piece and keep close to the wound. So that time that the maggots will come out. So you can remove with your artery forceps and put it in the hot water. And the one important message I want to convey with you all is don't follow maggots. So if you follow maggots, I already said there are a lot of pocket formation inside the wound. They will go inside and keep safe there. So there, if you follow maggots, what happen? Your artery forces will damage the blood vessels. So that time the patients will develop bleeding. So don't follow maggots. When they come out, you can take it out. Otherwise, leave it there. So after few hours, they will. After few minutes, they'll come out. So that time you can able to remove it. So this is how we manage the maggots. Any questions? So if you don't have a questions, so I go back to my case scenario. The patients will ask you about why God punished me like this. How will you respond? So the patient says like, sister, why God punished me like this? How will you respond? Nancy was asking a question. How will we minimize the pain? So, if sometimes the patients have two different types of pain, while we assess the wound, you have to ask the patients what kind of pain they have. So, nociceptive pain and neuropathic pain might have. So that time, if they have a nociceptive pain there, your systemic analgesics will work. Systemic analgesics means like any analgesics, morphine or ibuprofen or tramadol, all analgesics will help. That is systemic analgesics. So if the pain is not neuropathic, that time these kind of medications will not work. Okay, so that time you can use local anesthetic agent like sensorcaine, bupivacaine or xylocaine. Okay, you can take 1 ml and add 2 ml of normal saline and dilute it and put that area, that spread down that area. So within 2 to 10 minutes, the patients will get a local anesthetic effect on that area. Then you can do the dressings properly. Okay. Any other questions? So if you don't have questions, please ask my next second question. Please answer. Anybody? Definitely, if they ask this kind of question, you will say something. We'll ask open-ended question. Very good. Sumit, you are right. So what is the open-ended question you will ask? Why do you feel so? Okay. Any other points? Any other points? Aditi Goswami said, gave sympathy to the patient and tell it's normal thing to happen in this world with many people. So don't worry about that. How do you feel? Others, please respond. Aditi's answers. Do you agree? How many of you agree with this? Please respond. We cannot be sympathetic with patient. Okay. I'll give a therapeutic touch, leaning forward, and would it say, don't worry about that because it is causing him worry, concern, and uncertainty. Okay. Then, okay. Liana, how do you feel?
Yes,
That,
please.
yeah.
Excuse me?
Yeah, how do you feel that Aditi Goswami's response? So, what is your comments on that?
I'm confused by your question. I'm sorry.
Yeah, so Aditi Goswami, did you see that Aditi Goswami's comment on the chat?
About saying don't worry.
Yes. Gave a
Yeah.
sympathy to the patient and tell it's normal thing to happen in this world with many people. Don't worry about that.
I don't
agree?
think that's a good thing to say because it's kind of deminimizing our patients' feelings and concerns. And so it's better to ask open-ended questions. Tell me more. Why are you feeling like that? I would even ask like, what does faith mean to you? Or tell me more about God that you believe in. Open-ended questions for sure.
So, thank you. Thank you for your contributions because if they ask that kind of spiritual questions with you, then you can listen and ask them. So, as one of you have mentioned earlier, you have to ask them, you can ask some open-ended question like, so why you are thinking like that? Any problems, you can listen, you are ready to listen their problems. Okay, then you can show your face, okay, I'm ready to listen your problems. So what happened, why are you thinking like that? So that kind of questions you can tell them, ask me, ask her or his. So then the thing is, if they are in front of the caregivers, they will be telling that the caregivers will take care of everything. So but if you do the individual conversation, the patients might be saying like, so nobody is caring me, so no, everybody is reluctant to me, maybe nobody is allowing that within the house also they are not accept the patient, they are not willing that allowing the patient to get out of the room, so they always keep the patient there. So that kind of things will be affecting the patients emotionally, and they that time they might be thinking like, why God punished me like this? These kind of things will, the emotions will be expressed out. So that time do one thing, listen, and you can just ask open-ended questions like, so why you are thinking like that? So is there any problems? That kind of why you are thinking these that why you're putting these questions towards me like that. So that kind of things you can ask these kind of open-ended questions to them, and then they can able to share their emotions. Once they share their emotions, we can able to reduce their mental stress also. So that is most of the time, nobody is there to listen their problems. So isolation is also another problem. So that time you can do one thing, if possible, you can do the individual assessment and try to listen the problems in total. So any other points you want to discuss?
Hello, ma'am. Hello.
Yes.
Yeah, ma'am, can we use hydroperoxide ma'am for removing maggots.
No, hydrogen peroxide may not help. Hydrogen peroxide may not help. So we are not using hydrogen peroxide. If there is a maggots there, turpentine oil we'll use for removing maggots.
Okay, ma'am.
Do you
Thank
use?
No, ma'am, still, but we asking.
Oh yeah, okay.
Yeah.
It's not using. It's not help. No questions? So, if you don't have any questions, we can wind up the session. So today we have learned about fungating wound, cancer wound. So the major difference between cancer wound and pressure ulcer also we know that pressure ulcer is preventable and curable. This is not preventable and not curable. So there are a lot of that problems will be there. Physical, emotional, social, and spiritual problem will be there. So if possible, you can do the individual assessment. Then only we can able to know the full picture of the patient. And also we learned about how to assess the wound. And we learned about the management part also. If they have pain, you can do the pain management. Before doing the dressings, you have to make sure that whether the patient is pain free or not. If they have pain, there you have to give a small dose of the analgesics, and after 45 minutes the patients will pain free, and then you can do the dressings. And if they have a malodor there also, you can try with a apply metronidazole powder. Metronidazole powder is one of the good medications for controlling anaerobic bacterial infections. You can either use injection metronidazole, or after also you can apply metronidazole powder. If they have a head and neck cancers, the lot of foul smell will be there. You can use nebulization also. Same nebulization, instead of asthalin or butyrate, you can that pour metronidazole injection, and that fumes will help to reduce the infection. Most of the time head and neck cancers we used to use that nebulization also. And also controlling exudate also depends upon the patient's size of the wound and the quantity of exudate. You can that educate the patient about the dressings changes and all. So that kind of things you can keep it in mind whenever you have seen this kind of patients. Always try to prevent maggots. So you have to make them understand how these maggots come. It comes from flies. So they have to remove, they have to cover the wound as much as that all the times. That is very, very important. So if there is maggots develop, you can remove the maggots with turpentine oil. It's not directly poured to the wound. You can soak the turpentine with gauze piece and keep close to the wound. That time the maggots will come out. That you can take it out with the arthrophoses. Okay, thank you all for joining in, and thank you for your contributions. Before leaving the session, I would like to ask one question. So I have received only 20 assignments.